First of all, thank you very much, everyone, for coming. My name is Bill Kirby. I'm the moderator for this evening, and I am with Citizens for a Better Cambridge. Tonight is a panel discussion regarding SIS, or Supervised Injection Sites. We have 5 panelists, 4 of whom have arrived. The 5th is on his way, and I'm sure he will join us very shortly. I want to thank you all for coming. I know that the roads are a little slick, and when you leave tonight, please be careful and drive safely. For a Better Cambridge is a grassroots group that is interested in improving how we live our lives here in Cambridge and in Waterloo region. And tonight is part of that, making sure that we provide information to the community, as well as giving the community an opportunity to give information back to the people in terms of how they feel regarding the goings-on and what we might be doing about the things that are distressing our community. We have 5 panelists tonight, and I'm going to introduce them to you now. First, on my far right, your far left, is Dr. Michael Beazely. He is an associate professor at the University of Waterloo School of Pharmacy and a member of the Waterloo Region Integrated Drug Strategy Team. Next to him is Chief Bryan Larkin. He's the chief of the Waterloo Region Police Service and the current president of the Ontario Association of Police Chiefs. Our missing panelist at the moment is Michael Parkinson, and I will tell you that Mr. Parkinson is a drug strategy specialist and community engagement coordinator with the Waterloo Region Crime Prevention Council. He will be joining us shortly. Second from the left is Dennis Purcell, and Dennis is the Chief Building Official and Director of Building and Bylaw Enforcement for the City of Cambridge. He is also the Staff Liaison for the Public Safety Subcommittee of the Mayor's Community Task Force. And finally, on the far left of the table is Karen Quigley-Hobbs, who has been the public health nurse with the Region of Waterloo Public Health since 1981. And is the Director of Infectious Diseases, Dental and Sexual Health, and the Chief Nursing Officer for Waterloo Region. Please welcome our panel. For your information, the way we will proceed tonight is that we have a series of prescribed questions for our panel, which I will read out. The question will subsequently appear on the screen, and I will name the panelist who will be answering that question. Following the prescribed questions, the audience will have an opportunity to ask questions of their own, and we will have 2 attendants on each aisle with a microphone. So when the time comes, you will see it says Q&A on the screen, and this will be your opportunity to line up in the aisle and ask your question of our panel. Following that, there will be a couple of closing comments, and we will invite you to engage in perhaps some more casual question asking in the lobby, and sign up for information through For a Better Cambridge. Also, for privacy purposes, we are recording on video tonight's panel discussion, so if anyone is uncomfortable with that, you may move yourselves to the back of the room, but we want to make sure that you're aware that tonight is being video recorded. All right, and I see that Mr. Parkinson has arrived. Michael, if you'd like to just come up on stage, your seat is right in the middle, and you can join. We're about to head into the questions, and I can tell you, you are not the first one. All right. So question number 1, which is for Dr. Beazely. Is opioid use a choice, and is opioid use a health issue or a criminal justice issue?
Great, thanks. Thanks very much for those questions, and just wanted to quickly thank everyone who was able to attend this evening. So is that a yes/no question at the top? So healthy decision-making is part of all aspects of health and disease, and opioid use can certainly be a choice. You can choose to purchase an illicit opioid. When you're prescribed an opioid, you have some autonomy and choice as to whether you will take it as directed. As you start to learn more and more about substance use, biological basis of addiction, mechanisms of dependence, withdrawal symptoms, factors associated with substance use and addiction, such as trauma, The issue of choice is still there, but in a sense it becomes less and less pressing and relevant. I think mental health and addiction is an interesting area because on one hand we can relate to substance use disorder and some other mental health issues. We can engage in some forms of substance use without developing an addiction. We can display aspects or feelings of depression or anxiety without being diagnosed with depression or an anxiety disorder. So on one hand, we can relate to some of these things, and on the other hand, it makes it more difficult to understand these illnesses because we can relate to them. Then we sort of we reflect on our experience and say, well, I was in a situation like that, and I did something different. And so when you're on the sort of outside looking in, if you say, well, I was in that situation, I stopped, it's hard to understand why someone isn't stopping, when someone's continuing some behaviors that aren't healthy. It doesn't appear logical. And if you listen to former substance users, you'll hear terminology, and you've probably heard it before: trapped, slave to the drug, consumed my life, and it sort of give us a glimpse of kind of the difference between choice and the perception of choice, and what we might look at as a reasonable choice from the outside might not be perceived as a choice during that addiction. Is opioid use a health issue or criminal justice issue? Opioid use is a health issue, period. Opioid trafficking is a justice issue, and selling heroin to someone that actually contains fentanyl is a criminal justice issue. Diverting prescription opioids is a criminal justice issue. And taking a step back, the opioid crisis is an everything issue. It's a health issue and a criminal justice issue. And as I think we'll probably get a good sense of tonight, a public health issue, a housing issue, a poverty issue, an education issue, an opportunities issue.
Thank you. Question number 2. This is for Mr. Parkinson. How bad is the opioid crisis? What are the substances used and overdose trends? Is Cambridge worse than the rest of the region or other similar cities? And who are the most impacted by this opioid crisis? Street users or users who have homes? How many opioid deaths are the result of injecting drugs versus inhaling or smoking?
Well, it's like the 5-in-1 question here. I'll give it my best shot. In 2 words, the opioid crisis, it's bad, and not to be the Grim Reaper, late arrival, but it's likely to get worse before it gets better, and we've known that for a few years. So I think that, the good news is the people at this table, in this theater and beyond, are coming together to collaborate in an effort to save lives and reduce harm. And truly, that's what it's all about. If there's something more important than saving lives, then that's a conversation Canadians need to have. So in terms of data, every data release in Canada is worse than the last data release. In 2000 in Ontario, there were 111 opioid-related overdose deaths. Most of those would have been due to prescription opioids, and that's generally been the trend up until the present day. And the present day doesn't look very good. We saw a release from the province last week, which indicates for a 3-month period a 68% rise in opioid-related fatalities in Ontario. So that's about 1 death every 7 hours. And for context, we lose someone on Ontario's roadways every 18 hours. I suspect opioid overdose fatalities in Ontario are likely the second leading cause of acute deaths. Falls would be number 1, and some years ago it would have been motor vehicle collisions. And it's not unique to Ontario. Our federal health minister has called it an emergency, has called it a crisis, has called it an epidemic. We've seen similar calls at the provincial level, whether you're in BC or whether you're in Alberta or whether you're in Ontario. What has been striking for those of us who've been paying attention over the years is the response has not been proportional to what we might devote to other important but less common forms of death and injury. If you think about SARS and H1N1 and how we react to those kinds of conditions, it's a very different kind of response. In terms of who's dying, historically it's around opioids, it's people who are using exactly as prescribed by their physician. And I often think, if you wanted to set the perfect conditions for a black market, well, then you would provide hundreds of millions of dollars worth of prescription opioids through trusted health providers into a largely unsuspecting public. And that's what's happened in Canada, that's what's happened in the US, and that's why worldwide we're the leading consumers of prescription opioids, a substance we know is inherently addictive and dangerous. And so in terms of who's dying, it's people using as prescribed and people who are not using as prescribed. And historically, it's tilted towards people who don't have the same kind of protective factors that we might enjoy in this theater at this table, things like income, things like an absence of childhood abuse, trauma, neglect, mental health, and so on. Increasingly, that demographic is starting to change, and that's why you see paramedics and coroners.
Okay, Mr. Parkinson, I'll ask you to just put a final remark on that question.
And so that's why you see coroners and paramedics going to addresses that they traditionally didn't go to. So,
thank you. Question number 3 is again for Dr. Beazely. What is Waterloo Region's plan for the current opioid? What is Waterloo Region's current opioid response plan?
Sure. So I'm here representing the Waterloo Region Integrated Drug Strategy, which is tasked with implementing recommendations in a document that was endorsed by the region in 2011. And I've been associated with that work since 2008, and Michael's even further into the past than that. A lot of that work to create that regional drug strategy was developed in 2007, 8, 9, and 10. So certainly pre-fentanyl and opioid crisis, back when we were dealing with a lot of diverted OxyContin. So that's just giving you the sort of background of where the drug strategy, when it was created. So, but that's not to say we're not doing multiple opioid-related initiatives. Some are prevention focused, so take back your medicine to the pharmacy for safe disposal programs, online prevention resources for youth, more recently fentanyl information sessions for service providers, including police, social workers, and others, information nights for parents, teachers, youth, and so forth. Some are harm reduction focused, and so those would include expanded access to naloxone, an opioid overdose monitoring system, overdose awareness day events in 2016, 2017, and some of the work is treatment focused, including facilitating the creation of what are called RACs, or Rapid Access Addiction Clinics, and advocating the province for additional health funding to expand high-quality addiction counseling, day and residential treatment programs, and so that individuals can get treatment when they need it. So we're doing a great deal, and that's just a sort of a snippet of the opioid-related work that's happening as part of the drug strategy. There's other initiatives happening elsewhere as well. Much more recently, just last week, in a presentation to Regional Council, Regional Waterloo Public Health announced as part of some funding from the province that they will be creating what's called the Waterloo Region Opioid Response Plan, and that the drug strategy will be partnering with public health to create that plan. What that will do is kind of take all of this opioid-related work, put it into a regional response plan. It's not to say that the other ongoing work with prevention and other substances will go away, but we'll have a focused plan that we have started working on and continue to work on, and we'll be doing that in partnership with public health.
Thank you. Question number 4. The definition of harm reduction, which is stated as follows on the public health website, is harm reduction refers to policies, programs, and practices that aim primarily to reduce the adverse health, social, and economic consequences of the use of legal and illegal psychoactive drugs without necessarily reducing drug consumption or insisting on abstinence. So for Karen Quigley-Hobbs, another multi-part question. What are the region's current harm reduction programs, and are they working? What are the region's future plans for harm reduction? Isn't reducing drug consumption part of your mandate, and isn't the community impact assessment part of your mandate as well?
Okay. Thank you. Good evening. Harm reduction includes a set of practical interventions aimed at reducing the negative consequences associated with drug use, while at the same time recognizing the power that addiction and that for some people abstinence is not possible at this time. So harm reduction really is about reducing the damage to the health that may come from the drug use, and that will include overdose death, acquisition of HIV, Hep C, and a number of dangerous bacterial infections that are not only devastating to the individual, but also result in significant costs to the healthcare system. Public health is required by the Ministry of Health and Long-Term Care to ensure access to evidence-based harm reduction programs, including the provision of sterile needles and syringes. Other services include naloxone distribution and training, condom distribution, and access to birth control. Public health harm reduction programs are offered in partnership with many service providers. Future plans in partnership with the Harm Reduction Committee of the Waterloo Region Integrated Drug Strategy were endorsed by Regional Council in their role as the Board of Health in June of this year. And the listed plans included exploring the feasibility of supervised injection services in Waterloo Region, working with healthcare providers to improve their knowledge of harm reduction and their capacity to serve individuals who use substances, identifying and working with new community partners to provide harm reduction services, including needle disposal, and exploring opportunities and funding to expand outreach mobile initiatives in the community. So for example, peer programs and the Sanguine Van, and also to better reach our priority populations in rural communities. Recently, you will have heard in the news, the province has enhanced public health programming, specifically as it relates to naloxone distribution and training to family and friends of substance users, and then the recent expanded use to include community service providers and distribution to police services and fire services. Our surveillance of reportable diseases is a key part of our mandate, and it indicates that our programs are working. Waterloo Region HIV rates are consistently lower than those compared to the province, as well as Hep C rates, and indications for 2017 show a continued downward trend. Public health's mandate is two-part: creation and implementation of harm reduction programs and services in partnership with community agencies, as well as a substance use component where it focuses on prevention programs and services.
Thank you. Question number 5. Again, a quote from the Public Health website. There is substantial evidence that harm reduction is an important strategy in reducing the negative consequences of substance use, especially by preventing the spread of blood-borne infections. And based on this evidence, the Ministry of Health and Long-Term Care requires health units to offer needle syringe, and other harm reduction programs. So the questions are, again, multi-part for Karen. We must distribute needles. No option? Why not a one-for-one needle exchange or reusable needles? Needles are handed out at the Bridges shelter, and doesn't this encourage dealers and more substance use there? Why at the Bridges and not at other shelters? Will SIS replace the free needle program, and will SIS help reduce the quantity of discarded needles?
So as you mentioned, public health is required to ensure access to evidence-based harm reduction programs, including the provision of sterile needles and syringes, also known as our needle syringe program. It's part of our mandate. And it's included in our programs and services as outlined by the Ministry of Health and Long-Term Care. One-for-one needle exchange or syringe programs are shown to negatively impact disease rates as they lead to increased needle sharing and needle reusing. Access to clean needles are key to keeping rates of needle using and reusing and sharing low. Good access to needle syringe programs also equals good access to disposal. These programs have and will continue to exist outside of plans for supervised injection services. These programs are established based on need. They do not encourage drug use and do not encourage injection as a method of use. And if you think back to the original definition of harm reduction, it is actually that. It's an intent to reduce harm. Program statistics from public health clinics has shown that the proportion of harm reduction clients at our clinic at 150 Main has increased since 2014. However, fewer needles through public health services and our Cambridge partners are distributed compared to our clinic and other service providers combined in Kitchener-Waterloo. The needle syringe program improves access to harm reduction, supplies, and disposal. Partnerships are established with agencies that are both interested in providing these services and serve the target population. In Cambridge and historically, the bridges were well positioned to provide this support. And based on need, Aqua also provides this service in Cambridge through the Self-Help Food Bank. And the Sanguine Band also provides mobile support in Cambridge on Fridays. While the SIS in Canada are new interventions, studies to date regarding their effectiveness indicate that success with reducing the number of discarded needles in the areas surrounding the facility. A survey conducted by Public Health in 2016 showed barriers to properly disposing needles to be related to stigma. So people are using in hidden areas. There's public injection, and they need to get out of an area quickly and having nowhere to discard. We believe SIS will in part address some of these issues by providing a safe place to inject, and as well providing those supplies at the time of injection. SIS reduces the need to inject in public places, so instead of using bathrooms, trails, and other isolated areas, substance users will be able to use at these sites. And as I said before, they'll be provided supplies for injection and disposal as part of this service, as well as other counseling or health care that they may need.
Thank you. Question number 6 is for Dennis Purcell. Used needles are a major community concern, and citizens groups have had to mount cleanup campaigns themselves. The questions are, the city recently launched a new community ambassador program to help. What is it, and is it working? And are there any future plans for expanding the community ambassador program?
Thank you, Bill. Good evening, everyone. In response to increased reported incidents of discarded needles and drug-related debris in the city, and in response to the concerns that were reported by citizens in Cambridge about confusion over the jurisdiction and slow response time to some of those concerns, and also, as mentioned, an increased community interest in conducting community cleanups on public spaces. In response to that, the city established a process for reporting needle debris in the city of Cambridge, and also with a very aggressive timeline and mandate, an internal team of staff was pulled together to formulate a city response. And what came out of that was the city community ambassador program. And the objective of this community ambassador program was to implement and operate a team that would manage waste and debris in the city, including abandoned clothing, discarded items, needles and needle debris, and other associated items. The community ambassador program has two components to it. One is the community ambassador team itself, which is a team of dedicated staff that undertake proactive and reactive efforts to remove waste and debris from both public and private property. And the second piece is a community volunteer cleanup support, where staff support the community efforts with training, equipment, resources, and waste disposal. The community ambassador team itself has two purposes. One is to do proactive patrols throughout the city, particularly areas that are known to be what we call hotspots, and their responsibility is to find, collect, and dispose of the waste and the debris. But also that team is reacting to reported concerns that come in. So the community ambassador team responds to reports of waste and debris on public and on private property. The team may refer a concern out to the property owner. They may refer it to another city division like the bylaw team, where property standards bylaws may be more appropriate, or they will distribute it out to a third-party contractor if the volume of the waste dictates that. So the team is composed of 1 lead hand and 8 temporary staff members, and those teams are divided into 2 teams of 4 people. Each day has 2 shifts, one from 7 a.m. to 3 p.m., and the other is 9 to 5, and that includes the weekends. And that team is empowered to be able to evaluate the concerns that come in. They can determine its priority, they can determine if they need to request police attendance, if they need to get a contractor to help with the cleanup, or if it should be referred to another city division, or if the property owner themselves need to be involved in the cleanup. One of the interesting things was we got our tech services team to help us develop a mobile app that the team has when they're out in the field. They can pinpoint exactly where the debris is found. They can use that app to input the information that goes back to a database, as data collection is very important for what we're doing with this. The community ambassador team is equipped with Kevlar gloves and boots, tablets, sharp disposal equipment, and they're a very engaged, enthusiastic team, very well led. We have 3 reporting methods at the city to report concerns: through the telephone, through an online
Dennis,
intake
final
form,
remark?
and email.
Thank you. Question number 7, again for Dr. Beazely. Doesn't SIS just enable and condone drug use? And instead of SIS, shouldn't we be trying to address the cause of opioid addiction?
Thank you. So SIS can certainly enable safer drug use. But as Karen mentioned, by definition, harm reduction is neutral towards ongoing substance use, with the focus rather on mitigating harms associated with that substance use. And the sort of overarching idea behind those initiatives is one of non-judgment. So, and that goes both ways, not condoning or stigmatizing substance use. I think the question would be for the second point, is it instead of or in addition to? And certainly with the work of the regional drug strategy and others, one of the strengths in this region, I think, is the understanding that we need to address this problem through multiple approaches in a coordinated fashion. And so the question, I think, is in addition to addressing root causes of opioid addiction, and in addition to pursuing treatment, in addition to improving justice and enforcement, is SIS part of that comprehensive strategy? And so there's no reason why harm reduction and prevention would ever need to be mutually exclusive. In fact, I think they work much better when they aren't mutually exclusive, and when the messaging, when the prevention messaging can actually complement harm reduction messaging and interventions. So I think the question is, from a comprehensive point of view, is a supervised injection service a part of that, and how will that work with existing initiatives?
Thank you. Question number 8 is for Karen, again, because we love those multi-part questions. What is the SIS role of federal, provincial, regional, and municipal governments? How many active SIS locations are there in Canada today, and where? Are there any cities in Canada that have decided against SIS? Are there any SIS locations in cities as small as Cambridge, and will SIS in Waterloo Region be restricted to clients from Waterloo Region only?
Currently, an exemption to the Controlled Drugs and Substances Act must be attained from the Federal Minister of Health to legally operate a supervised injection service in Canada. The exemption related to consumption more generally. To be funded, an application to the Ministry of Health and Long-Term Care must be submitted. Currently, funding is only provided for injection activities. The Provincial Minister of Health and Long-Term Care is also required to provide a letter of support in order for federal applications to be approved. Last week, we received news that the Ministry of Health and the federal government will be looking to streamline these funding and approval mechanisms in terms of temporary overdose prevention sites. At this time, we have no other information to provide around that approval process. Locally, it's public health's role, specifically to SIS, to lead the feasibility study, which is underway right now. It's a study that is a process to determine the need for supervised injection services and to gain broad community input into the perceived benefits and challenges these services may provide. The aim of the study was to ensure everybody had some way to provide some input. A report to the Community Services Committee in early 2018 will include findings related to community need and recommendations for next steps. At that point in time, the Board of Health or Regional Council will determine if the feasibility study has actually revealed a need for the Waterloo region as a whole to implement one arm of, or this arm of harm reduction services, that being SIS sites. The applications must include a consultation report that summarizes hopes for such services as well as concerns and a mitigation strategy to deal with those concerns. And that includes consulting with municipalities. Assuming an endorsement from the Board of Health, we would move into that in phase 2. Right now, we're not there. We're still analyzing the information from the feasibility study to determine or to put together a report so that the Board of Health can determine if a need exists. The Ministry recognizes the important role that the local governments play as partners in service delivery, and applications should demonstrate support from local councils. There are currently 15 SIS operations in Canada. Some are in larger cities, some are in smaller. They include Kamloops and Kelowna, which are both smaller than Cambridge. Surrey, Vancouver has 3 sites. Calgary, Ottawa with 2 sites, and Montreal with 4 sites. Kamloops has a lower population, as I said, as well as Lethbridge. 12 more cities have received federal exemptions and sites are being prepared. And these include Victoria, Calgary with 3 sites, Edmonton 4 sites, Lethbridge, Ottawa, Toronto has 2 sites. Lethbridge is comparable, as I said, or lower to Cambridge in terms of population. London, Thunder Bay, and Waterloo region are at various points in their feasibility study, and as you would have seen in the media, I believe last week, Hamilton Board of Health approved the need for SIS services in the city of Hamilton.
Thank you very much. Question number 9, not to feel left out, this one is for Chief Larkin. Why are some police forces opposed to SIS? You recently decided to support SIS. What were your concerns and what did change your mind? What is the potential SIS impact on community security and public safety?
Thanks, Bill, and good evening, everyone. Pleasure to be here this evening, both as your local chief as well as the president of the Ontario Chiefs. And as Dr. Beazely alluded, much has changed over the last number of years. And so our police service, as well as the Ontario Chiefs and Canadian Chiefs, have been heavily involved in the dialogue of SIS sites. In particular, I think in 2011, our police service locally, we were a part of the integrated drug strategy, but we did not participate nor did we support the harm reduction pillar. We focused mostly on enforcement and other aspects. The reality is that some police services have concerns. Naturally, we want to balance public safety along with some of the different pieces. But I think over the last 7 years, we've seen a significant change. And so the tables that I sit at with the chiefs and police leaders across Ontario and Canada, we're not opposing. We have concerns. There's some unknowns. There may be fear and trepidation. But our position has always been, this is a health issue. This is a public health issue. In 2014, I appeared before the Senate Committee on Bill C-37 on behalf of Canadian Chiefs, and our message was very clear. We want to work with public health. We want to ensure community safety, as this is a health issue. It's not a judicial issue. Some of you have heard me say this before. We're never going to arrest our way out of the opioid crisis. It's the most complex, most challenging drug issue that we've seen in policing in generations. We've survived crack cocaine, we've survived crystal meth, we've survived OxyContin. This has presented a significant piece. And so the second piece around that, and so it's not that we have opposition, we have concerns. That's part of our role around public safety. But the reality is, as you can see from Karen, 15 sites moving across Canada. I can tell you that in all of those communities, the police chief was a big supporter and a big part of advancing and moving those things forward to ensure that we're part of the dialogue. The second piece around why did I support or recently decide to support or change my mind? I've never changed my mind. I've always been a supporter. And Heather Kerr's here, the Executive Director of Stonehenge Therapeutic Drug Center in Guelph and Wellington County. I chaired that board. And so my perspective as a police officer has always been very different around substance abuse and drug use. And so I recently became public because the media, after a police services board meeting, asked me. Previous to that, nobody had asked me in a public context. And so I appeared before Regional Council last week with a number of partners at this table and reiterated the fact that we need different tools. 400 calls for service to the police service this year around overdoses year to date. 65 deaths in our region year to date. We can't sustain this from a policing perspective, and also some of the other challenges. The third piece around community security and public safety, it's real. It's a balancing act and it's a precarious position for police. We enforce federal laws. Illicit drugs are obviously a concern, they're not illegal, and yet at the same time we have to balance the need around this health crisis. And so how do we do that? It's challenging. This is one of the ways that we do it, is through these engagement, these dialogues as we move forward.
Thank you, Chief Larkin. Question number 10, again for Michael Parkinson. Won't SIS attract more drug users to our city with associated drug dealers and crime? Are we sure there is sufficient need to support an SIS in Cambridge, i.e. in particular the Galt downtown? We hear that 80% of overdose deaths occur in the suburbs. Isn't a downtown SIS irrelevant in the suburbs?
Well, I'll give you a 3-in-1 answer then. In terms of crime, I wouldn't expect really any difference. I wouldn't expect it to go up or down in the short term if consumption services are offered and those ancillary services like addiction treatment and so on and so forth are there. Then in the medium to long term, I would expect crime to go down. Not everyone who uses drugs is committing crimes, but we know when you look behind bars, there's a definite relationship when you go to the provincial and federal institutions. So, and that's really based on research out of Insight, which is the only site that's been evaluated in Canada because it's been the only service that's been going for any length of time. We would expect to see a decrease in what we call disorder, like discarded syringes and public ejecting, those kinds of things. But I don't think it's likely to attract new dealers. In terms of whether there's sufficient need to support an injection service in Cambridge, I mean, that's, I think, part of the purpose of the feasibility study. I mean, you have substance use going on here, just like every community right across Canada. And I think it's worth remembering that a supervised consumption site actually requires very little. You need a table, you need a chair, you need some supervision in case things go sideways, and you need some supplies. And that's really about it. So we've seen really small services exist inside hospitals, for example, and in Europe, I mean, much more creative than we have been to date in Canada. To the question of whether it's irrelevant in the suburbs, I mean, that's a challenge of this opioid crisis, is that, you know, out of British Columbia, we know that most people are dying in their homes. Sometimes those are in suburban areas, and oftentimes they're alone. So it's because people at risk these days are people who are using daily because they're dependent or addicted to opioids, and because it also includes people who are using casually. If you think about, you know, well, I don't mean to pick on lawyers, but, you know, 2 lawyers doing cocaine on the weekend and it's cut with fentanyl, how do you track those into a service? I don't know. But it's a real challenge in health services and public health to reach those people who are in the suburbs. But when we think about consumption services, we don't have to think about one storefront facility. It could be a multiple of, many smaller type facilities.
Thank you. Question 11, again for Michael Parkinson. And I know how you love these multi-part questions. SIS clients bring their own drugs and inject themselves on the premises. What impact does SIS have on overdose deaths, ambulance calls, HIV desire to quit, and other? Don't drug dealers like SIS since it will help them do even more business? Is there a risk of low SIS use due to location, confrontational security, etc.? What evidence is there that SIS locations can avoid becoming a drug zone? Once an SIS is opened, will it be almost impossible to close down later on?
Okay, on my mark, it's at go. Impact on overdose deaths. Well, no one's ever died at Insight. That's the bottom line. It simply doesn't happen. In terms of ambulance calls, there's evidence to show that you would see a decrease in ambulance calls because any overdoses or adverse effects are handled inside a supervised site. In terms of HIV, AIDS, and other blood-borne infections, you would expect to see a decline, and that's why supervised injection services like Insight in Vancouver pay for themselves in terms of avoiding future health care costs. In terms of improving or inciting a desire to quit using drugs in the first place, well, it depends on what other services are available. At Insight, they have a place upstairs called Detox, and both Insight and Detox have been full since day one. The point is, for people who are using services, they're typically distrustful of health services and others. Part of the idea really here is to establish a relationship, and for folks who want to quit or change the direction of their lives, there's someone there that they can talk to, and it's a trusting relationship, and sometimes that takes years. Sometimes it never happens at all, but it really depends on what other services are available. Do drug dealers like supervised injection services? I haven't seen any surveys. I think they're probably quite indifferent. It certainly doesn't incite people to use drugs or to begin injecting drugs. Is there a risk of low SIS usage due to location and security and that kind of thing? Yeah, that's possible. The details really do matter. You're talking about a population that is engaging in behavior that is contrary to the criminal code, about people who have not grown up with a lot of trust in their lives. So those details really do matter, including the kind of staff and location and so on and so forth. Is there evidence that SIS can avoid becoming a drug zone? Well, we have very little to evaluate against in Canada. At Insight, there's a rule there, and there's a culture that was built over time. So you're not allowed to pass things inside the building, and outside the building, if you were caught dealing in the early days, staff would rush out the door and say, no, not out front of this facility. So over time, that has worked to avoid creating that kind of drug zone. So newer facilities will be challenged to do that. And will it be impossible to close down later on? Well, nothing's impossible. These are a function of funding and whatnot. There's plenty of work on the table to do besides running a consumption service. Ideally, one day, yeah, we wouldn't have a need for those kinds of services, and that really speaks, I think, to the forte of the Crime Prevention Council, which is the sooner we begin engaging in upstream prevention, the better.
Thank you. Question 12 for Karen. Fixed location SIS, mobile SIS, and temporary tent SIS are different configurations. The question, again, multi-part. Can fixed SIS locations be kept small, spread out, and away from core business areas? Mobile SIS seems impractical since substance users can't wait for the next mobile site. Temporary tent SIS seems impractical for weather reasons and since opioid users can't follow them around when they move. SIS open hours can't match substance users' needs. doesn't this mean unsafe injections will only be reduced by a small percentage?
So in order for applications for exemption and funding, it's important that the need for the site must be shown in integration with other services, and accessibility requirements are an important consideration. Currently, there's only one mobile unit in Montreal that's been approved in Canada. It's really too early to gauge how effective it is. However, it will be important for us to keep our eye on this and assess how a mobile site may assist in ensuring access to SIS on a regular basis. And while temporary sites have had issues related to weather, they have been shown to be successful in preventing deaths. The implementation of a permanent supervised injection site is required that there's a number of different pieces of requirement, and it's a longer process, often requiring renovation for the site. It requires oftentimes an integration with other services to support it. At this time, a temporary site would have reduced criteria, recognizing that it would be temporary once the permanent site would be up and functioning. So it has a little more flexibility, and I believe the minister is hoping to be more responsive to the climbing number of deaths. So as I said earlier, we're expecting a bit more information with regards to approval and funding for those overdose prevention centers. It is expected that supervised injection sites target areas with high rates of overdose and problematic substance use. However, we are aware people who use injection drugs live in many areas across the region. And if our region decides to move forward, we do not expect that everyone who injects drugs will use the site. Our goal would be to target areas with the highest rates of overdose. Differing sites in Ontario have different operational hours, and our plan would include consulting data to determine the most optimal hours of operation. So if the Board of Health decides that the need has been established and they move forward with phase 2, those will be all important sections of that phase 2 consultation to ensure that what we design for the region of Waterloo and the locations fit the need and the demand.
Question number 13, again for Michael Parkinson. BC is launching a new overdose emergency response center initiative in hospitals to facilitate rapid responses to the opioid crisis. Is a hospital-based overdose emergency response center something we should be considering? What are hospitals in other cities doing to help with the opioid crisis, and do we need more detox treatment and emergency mental health services?
So in British Columbia, where a formal emergency declaration happened in early part of 2016 after an escalation of deaths there, a number of initiatives came forth, and more recently there's been a real revamp. And so I would encourage you, if you want to see what a decent provincial response looks like, to visit the BC government website to check that out. So the short answer to question 1 is yes. I don't know that we should be treating this crisis any different than we would any other health crisis. If you think about SARS and H1N1, the emergency protocols that exist for public health and for other agencies in disaster relief and that kind of thing, that's the kind of structure that's really needed. And it's not happening in most of Canada. It's really starting to get ramped up in British Columbia. So the protocols exist, and more recently this fall, the Ministry of Health did activate the Emergency Operations Center in Ontario. It's mostly an information exchange that's happening to date. In terms of what other hospitals in other cities are doing, I mean, I think they're doing what they can in the face of adverse conditions. You've got to bear in mind that the justice system, the hospital systems, they are so far downstream. And I would say that, you know, if there's, as a taxpayer, if there's 2 systems you never want to touch, it's Bryan's system, it's the justice system, and it's the hospital system, because they're just so so expensive. So it's painful to watch all those missed opportunities occur, and then we're going to incarcerate someone for $200,000 per person per year. It makes no sense on a financial basis. So, different hospitals are doing different things. In the Dr. Peters Center in Vancouver, many years ago, physicians and nurses were distressed by folks coming in with addictions, needed health care, couldn't wait around because they were going into withdrawal, and they would lose the client. And so what they did is they opened a supervised consumption site right on site and are providing good health care. Fraser Valley, health authority, if someone has an overdose, they'll contact the family physician. They'll make sure the person leaves with naloxone or is offered buprenorphine, those kinds of things. Boston Medical Center has a peer-based overdose prevention team, and so on and so forth. And finally, do we need more detox treatment, emergency health services? No. Of course we do. As a wiser woman said to me one time, if I came into the hospital with a burst appendix, the doctor doesn't say, you've got a burst appendix, come back and see me in 3 months, and in the meantime, don't act like you have a burst appendix. So the call from police and from other health providers is for treatment, addiction treatment on demand. That's the gold standard.
Thank you. Question 14 for Chief Larkin. Police presence around SIS locations must be almost non-existent or the SIS will not be used. The result is blatant drug dealing in public around the SIS. How can we be sure our SIS won't become a drug zone, since illegal narcotics must be tolerated in an SIS toleration zone, and how big does this toleration zone need to be?
Thanks, Bill. And again, that really raises the precarious position that we find ourselves in policing, is how do we support a public health opportunity, something that creates opportunities for those that use in a safe perspective, as well as how do we balance community safety and public safety around the SIS site. And again, one of the challenges is this is fairly new around launching and popping up across Canada, with the exception of Vancouver and Insight, which is, again, geographically a very different location and a different piece to really make any comparison to from other communities. And so I think the reality is the first thing we need to acknowledge is we have a problem now. And I think we need to acknowledge that. And so regardless of whether we have a specific area that is an SIS zone, we have challenges in different pockets across the region, including in Cambridge, including in Galt. And obviously when we move to Kitchener and uptown, and downtown Kitchener. So those are two areas where we see. We also recognize, as the evidence will show, that a majority of our overdose calls and deaths are often elsewhere in obviously suburban areas. And so how do we manage that? And I think that one of the things we're looking at and working in dialogue with Toronto and Ottawa is building the culture and building the relationship. And Michael talked about that. The Vancouver Police Department has an excellent relationship with Insight. They have opportunities to dialogue. They have assigned liaison officers. They have individuals that work and connect. They have social navigator officers similar to our community resource officers that are in those areas connecting with users, connecting with those that are in need. I think there's this myth or perception that police don't come in contact with the individuals that we deal with daily. That's false. It's a myth. We have some phenomenal relationships with people that use. We have some incredible relationships with people that suffer from significant mental health challenges. And in fact, often it's our patrol officers, our frontline officers, our community resource officers that connect with those individuals to make sure they're healthy, they're okay, they're heading in the right direction. And so there is some balance there. Around the toleration zone, I think that's what the feasibility study has to be about. Obviously, we've been a stakeholder in the dialogue with public health, and we have to look at some of those pieces. As I've publicly said, you can't have a police officer on every corner. The reality is people may not come. The other flip side of that is people who live around that area may say it's either really safe or it's unsafe. We all have a different perspective as to how we look at police presence. So I think it's really a measured approach, something that if and when the public health or regional council approves and there's some movement forward, a large dialogue around how do we balance that piece and how do we connect. I think the reality is that from the onset we may see some challenges. We've seen some challenges in other communities at the start. And I think that's where the measured approach is extremely important, so we set the context and the tone to ensure safety not only in the SIS location, but in the surrounding community.
Thank you. Question 15 is for Karen. A new peer-level program from the Regional Public Health is under development. It's called the Social Enterprise Initiative. What is the Social Enterprise Initiative about? What's the time frame for getting it started? And is it funded and happening for sure? Will Cambridge be involved?
Okay, so Public Health, Sanguine Health Centre in the City of Cambridge are partnering to launch a pilot project to address hotspots for needle litter in Cambridge. This is one activity within a comprehensive strategy that includes also fixed outdoor disposal kiosks, continued disposal through needle syringe program sites, and education. Coordinated by Sanguine and funded by Public Health, peer workers will be hired to walk routes and visit key areas searching for and picking up needles-related waste as they go. We hope to have the program in action by the end of winter 2018. Peer workers will play a major role in tracking statistics so the program's success can be measured. Statistics regarding needle complaints will inform the routes and locations visited by peer workers, which tend to change over time. Similar programs have been in place for many years in both Ottawa and London with very good success.
Thank you. Question number 16 is for Dennis Purcell. Trespassing incidents are up dramatically across the region and citizens need help. If police are the Tier 1, we need a new Tier 2 trespassing system to de-escalate trespassing incidents and free police to focus on drug dealers and serious crimes, ideally accessed via a 311 number. Is there any consideration being given to developing a Tier 2 type service? Would it provide assistance for trespassing incidents on private property? Would it have a role preventing SIS from becoming a drug zone for dealers? And will there be security cameras at any SIS locations?
Right now, we're in the early stages of looking to expand our community ambassador program. So we're looking at a number of opportunities. We're looking at a number of partnerships. We're looking at other things that we might be able to put into place. When we first put this community ambassador team together, we recognized right away that this provided us with a lot of other opportunities that we could take advantage to help make our community an even better place. Just this afternoon, we did meet with Public Health in regards to the social enterprise model and seeing what kind of opportunities there are there for something like that to help us augment the service that we're providing through the community ambassador team. Specifically implementing and using outreach workers who have lived experience, who could assist in helping the community ambassador team with needle cleanup, disposal, but also providing that additional service of reaching out to individuals who may be in distress or other types of situations that they face. So we are committed as a city to exploring those opportunities, exploring those partnerships, and seeing where we can take our community ambassador program. Right now we have, we're putting together Service Cambridge, which is going to be launching very soon at the city, and that's the city's opportunity to provide a much more enhanced, much more centralized customer service to the community and receiving complaints, concerns, providing information to the public, and so on. A natural evolution out of that type of a program could be something like 311. So one of the things that we talked about, Dan Clements and myself, when we were meeting in the aftermath of our first public safety subcommittee meeting, was potentially the difficulty of remembering the centralized number that we have for reporting incidents of needle debris, 519-623-1340. And suggesting to us that maybe a 311 would be a much easier number to remember. So that's something that we would look at down the road, something that we may be able to implement in the future. But these are things that we are looking at as a city. What does our community ambassador team look like over the winter? What does it look like in the spring? What does it look like in the long term? So certainly there may be opportunities that we can avail ourselves of in looking at these opportunities with Tier 2 and other opportunities that we have.
Thank you. Question number 17, again for Karen. Supervised injection services feasibility study will be presented to Regional Council soon, and if accepted, the next stage will be location assessments, presumably in the spring. Is SIS happening for sure, and can our region or city say no, or can we say no for now? Why is the whole process so rushed, and what is the public engagement plan from here forward? Can the public influence these serious decisions? Can we be guaranteed that Kitchener and Waterloo will also participate in SIS? Will the study consider a treatment-oriented alternative that cuts out drug dealers? And if not, can it be considered? Will the study have a community impact section with details on potential disruptions in any SIS neighborhood?
As I've said a couple of times, some of your questions are ahead of the game here. We're still in the process to determine if there is need in Waterloo region for an SIS site, and that is if people who inject drugs will use one and the conditions under which it will be used. We will be sharing these findings with Regional Council, who's our Board of Health, in early 2018. Regional endorsement of the need for an SIS is needed before we move forward. If you assume that, that there is a need established and that it's endorsed by Regional Council, at that point we will begin a more comprehensive approach to consideration of potential locations and council and community consultation process. The opioid crisis has had devastating consequences in our region and continues to have devastating consequences in terms of death and illness. It is the role of public health to identify and respond to issues related to the health of the community. So earlier this year, public health, along with partners who are actively involved in tackling the issue of substance use, identified the need to prioritize exploring this option for our community. A recommendation to move forward with this work was unanimously endorsed by Regional Council, which is comprised of our Regional Council and our municipal mayors. Data shows that no one area in Waterloo region has escaped overdose, but that largely they occur along the central transit area, and findings from the feasibility study regarding whether or not they are needed would be used, and they haven't been analyzed yet. So at this point, we're still processing the information, once we get into phase 2, we'll be able to establish what those areas of greatest need will be, and then to move forward with more extensive consultation. At this time, supervised injection services must incorporate access to prescription opioids. That incorporate access to prescription opioids are not permitted. People who use SIS must obtain their drugs before coming to the site. Part of the application must have a section that summarizes the community's identified challenges that relate to the SIS and how those will be mitigated. It's an integral part of the application process.
Thank you. Question 18, again for Chief Larkin. Right now, most SIS are in large urban areas or centers, but Cambridge is not large. Furthermore, it has 3 downtown cores. Won't SIS have a disproportionately significant impact on our very small downtown areas?
Thanks, Bill. And I think, again, have to look at the feasibility study because it's a bit of a hypothetical piece. But I also think we need to change our mindset in the landscape from our perspective is that crime, drug use, other public order and public disorder issues really, they do not obey geographical boundaries. And so from a policing perspective, when we look at policing the region, crime knows no boundaries. And in fact, that continues to change in the way that our investigations flow from one jurisdiction to another. Of course, our makeup as a police service is very geographically based, but the reality is when we look at some of the challenges that our members face, we see transition from one area to another area. We see, and often when we do crime suppression or significant work, it's like stepping on a balloon. We push and suppress and move crime and move issues elsewhere. And so it's not uncommon to do a lot of work, let's say, in the central part of the region, and all of a sudden the individuals that we were dealing with pop up elsewhere. That's part of the reality. We see a lot of transition from the Greater Toronto Area into our community, and we also see some transition from south of Cambridge, from the Hamilton area, that comes into our community and moves up. So I think we have to also look at the region is the 10th largest community in Canada. And so you look at it from a different perspective, that Cambridge is part of the region, but formulates part of the 10th largest community in Canada. With that comes significant challenges. And so it's very different. And again, I want to go back to the current perspective. Our current data shows is, yes, we have some challenges in particular. I'm going to speak very direct that we have some challenges in downtown Galt, in the neighborhood surrounding the Galt area. We're seeing different complaints. We see increase in call demand. But when we look at crime data, it's relative to other parts of not only the city of Cambridge, but relative based on per capita to other parts of the region. And so do we need to continue to increase and enhance policing? Yes, we do. That's a dialogue we're having ongoing with Mayor Craig and Mr. Dyke and the team around how do we increase and raise awareness. We've added a full-time resource to downtown Galt around addressing and moving, though. It's not about enforcement. It's about moving the needle upstream. It's about navigating the system so we can move individuals to the right direction into the healthcare system. So I think that, it's presumptive to think that there'll be a significant impact or it will change disproportionately. Some of the data doesn't show that. I mean, obviously, we're concerned about some fringe pieces. We're concerned about some nuisance crimes and other issues that come with typically other social challenges. But I think it's about getting to the root cause. Why do people break into cars? Why do people break into homes? And I think it's about changing the shift as to let's get upstream to manage the fact that they don't need to break into the car. They don't need to break into somebody's house. And so it's a difficult balance, but one that we're engaged in the dialogue, and one that I think the feasibility study will look at significantly, because we will supply crime analytics and police analytics, because we'll need to do a needs analysis on what the impact of the police service potentially could be.
Thank you. Question number 19 for Dr. Beazely. Two recent British Columbia newspaper headlines. No break in fentanyl deaths prompt BC to speed up efforts to get clean. Drugs to long-term addicts. 22 Vancouver BIAs demand an immediate expansion of opioid treatment options, including injectable therapy programs. Question, again, one of our favorites, a multi-part. Does the region's current opioid response plan consider treatment-based alternatives where drugs are provided and dealers are cut out? Before committing to SIS here, should we learn from BC's experiences and consider this treatment approach? What are barriers to a treatment-based approach? Public acceptance, funding? Is treatment with provided drugs the future, and should we just get on with it?
Great, thanks very much. And this is something I'll address briefly, and then I think this is something, if you're interested in, after the Q&A, we can chat about in the foyer. I brought research papers to go through if you're interested. So it's a complicated question. Of course, one of the reasons we're talking about an opioid crisis is the presence of fentanyl and using opioids, maybe thinking it's heroin and it's fentanyl, which is much more potent, much more dangerous, increases the risk of opioid overdose. And so one alternative is then, in addition to a supervised injection service, is to also prescribe or provide an opioid on site. And that's been done in various jurisdictions in Europe and piloted in Vancouver as well. Typically that has been prescription grade heroin that's been provided for the user on site, which really cuts out that risk of the variability in supply. So you're getting a known quantity of a known drug that's not contaminated to inject. As you might imagine, that brings resistance along with it from the public, from police, but also from health providers that aren't used to prescribing or using heroin as a medicine. It's typically thought of as an illicit substance. And so although the evidence is positive with the use of heroin in that manner, more recent study, very recent study, has used another opioid called hydromorphone in a similar manner. And that has a few advantages. Hydromorphone is used in pain management, and physicians and health professionals are familiar with it. Less sort of pushback and concern about hydromorphone use in that manner compared to heroin. And so very early evidence suggesting maybe that service is equivalent to heroin supply. Whether this ought to be part of the Waterloo region supervised injection sites in the short, medium, or long term will in fact depend, as the question suggests, on need, funding, availability, training of health professionals and other staff as well. And just for example, one of the Vancouver study leads on one of the heroin studies suggested that in the population that she was working with, about 10% of those opioid users would really benefit from prescription heroin instead of just traditional services. And so the question is that 10% in Vancouver, is that going to be the same number in Waterloo region or a different number? And if it's the same number, is that a sufficient number of individuals to add additional infrastructure for some of these additional initiatives? I think the question, to answer the third question, or the second question, I don't think it's reason on its own to delay an SIS discussion. I think that is important to question on its own merits, but certainly these are emerging, exciting initiatives that could play a part in the future in this region.
Thank you. Okay, and question 20 is for Michael Parkinson. Cambridge and the whole region has a serious shortage of rapid access clinics, treatment services, detox facilities, rehabilitation beds, mental health support, emergency shelter beds, transition housing, and affordable housing. Is there any evidence that expanding support services can impact substance abuse? Should we consider assessing the impact of the new rapid access clinic and street-level support programs before committing to SIS? Before we commit to SIS, should we consider a treatment-based approach?
Well, short story is, yes, if you provide services, you would see reductions in substance use, and particularly problematic substance use. You would see less people spitting through hospitals in the criminal justice system. So what's not to like about that? If you think in terms of the four-pillar approach, that's part of the drug strategies in Ontario at the community level and the federal level. The prevention piece is really about preventing or delaying the onset of substance use. And there are other countries in the world where upstream prevention is taken a little more serious than it is in Canada. And those kinds of countries provide appealing alternatives to using substances in the first place. And that's the gold standard. You think of places like Iceland they've seen double-digit reductions in the use of cannabis and use of tobacco and the use of alcohol. So stay tuned in February. We're going to bring some folks in from Iceland to talk about that kind of stuff. Everything else is sort of downstream, and that's not to say it's not needed. That's addiction treatment, that's harm reduction, that's the enforcement justice system. And the cost of untreated opioid addiction in Ontario, very, very conservatively, is about $45,000 per person per year. And those are costs accrued through health services, justice, and so on. And the cost of providing other addiction treatments is vastly cheaper. And so that's why I think it's frustrating to many in the field that there isn't a scaling up of those kinds of services. And yes, they do work. We've seen lots of evidence from the U.S., from Canada, and to the question coming to Michael around injectable hydromorphone. I mean, it's ironic, but it pays. And the evidence out of Crosstown Clinic, for example, in British Columbia, it costs $20,000 to put someone on that kind of program, but you see immediate results in crime reduction, homelessness, and so on and so forth. Compare that to $45,000 or $50,000 per person per year, and what's not to love about that? So in terms of assessing the impact of the new rapid access clinic. I mean, this is good news for Waterloo Region. Should we do that before committing to a consumption service? No, probably not. It would be ideal to evaluate it for sure, but we weren't sitting around evaluating interventions when it came to SARS, when it came to H1N1, when it came to just about any other health crisis that Canadians have faced before. This is when Minister Philpott says we need an all-hands-on-deck approach, she means an all-hands-on-deck approach, not just the people at this table, but the people in this theater as well. So welcome to the team, basically. And before committing to an SIS, should we consider a treatment-based approach? Again, I think you need all those different initiatives within that sort of four-pillar framework. We need a response that is urgent, that is proportional to the crisis beforehand, that is collaborative. And as the Crime Prevention Council would say, we need targets, timelines, and dedicated resources. You can't do this by funding initiatives through bake sales and GoFundMe accounts. So you need the whole package, and you need to work on it concurrently. Thank you.
Thank you, Michael. All right, this concludes the prescribed questions that we have, and I would ask our panel, given that some of the answers could have been far more expansive than we've had time to allow, if you would be kind enough to provide your answers via email to us, then we can post that on our website, and we thank you for that.